where are the gate videos? If you go into clinical courses, or you can just go into courses, you will definitely find this as a clinical demonstration in neurology by Dr. Achin Mehra. That's the title for this. Okay, it's easily found there, no problem in that. So you can go to the clinical courses, or you can just go into all courses and then see for the clinical demonstration in neurology by Dr. Achin Mehra. You'll find it there, don't worry. The gate videos are there waiting for you. You have to go there to them with a fascinating gate, right? Or maybe kinesia paradoxa. Topic for today will complete Parkinsonism, and we'll also discuss the test discussion. Yes, if I'll not be very I'll be very quick in the discussion there. Okay, because many questions there. See, in conduction aphasia, what happens is the Broca's and the Wernicke's area are losing connection with each other through the arcuate fibers. So the Broca's might develop a word and it comes out on its own, right? Instead, what happens is somewhere in between the arcuate fibers are helpful to connect the Broca's with the Wernicke's backward. So if the connection is broken, the Broca's will form a word and put it out. So the speech that the person speaks out might be in a sense overfluent. It will be in explosive manner, okay, like a patient of Wernicke's. Okay. How is spasticity velocity dependent? Now this is something important that we find somewhere when we keep on rotating the elbow joint like this. In spasticity, the contraction on these muscles which are having increase in tone keeps on increasing actually. So what happens in spastic phenomena, when we keep on moving, the rigidity that I'm going to feel or the stiffness I'm going to feel will always keep on increasing. Why tremors occur in Parkinsonism? I'll come to that today, don't worry. Picture abhi baki hai. Alexia means the pure word blindness. Okay. Okay, pure word blindness. You can compare with your Amazon Alexa also, because she is blind to words, but she can hear your words, right? But that's not a very good comparison to explain. But what happens in Alexia, the visual cortex is not connected with the area where the image of the word is stored in the brain. So it is the splenium part of the corpus callosum which happens to become a connection between the two things. That has been destroyed. Now the point is, the visual cortex is very well connected to an area where you find the right name of the object, because you have an image of the object already in your brain. Like this looks like a mobile phone, that looks like a pen. So what happens, you can easily differentiate between the two things and tell me. So that's an important thing, that the naming is intact in them, because the visual cortex connected with the Wernicke's to make me understand what object it is. I'm able to judge it, but the word which is kept in front of me, I cannot at all read it, right? I'll come to Lewy body dementia today, don't worry. Why is spasticity beneficial? You've seen the video yesterday. Circumduction gait, when I'm keeping the weak limb on the floor, the weak limb is stiff, okay? So I'm keeping the weak limb on the floor, the weak limb is stiff. I can take the support of this stiff limb and pull ahead the normal limb. So spasticity in a sense is beneficial to maintain balance, especially if I'm walking, because if I'm walking with a weak limb, obviously I'm going to fall down the moment I keep it on the floor, right? Happy Thursday. Oh God, I actually don't know what day of the week is, because every day is a Sunday for me nowadays at home. Okay, happy Thursday. See, Parkinsonism is always an extrapyramidal. If you remember the nigrostriatal pathway, it was an extrapyramidal track. You know, it was sending some impulses through dopamine to the basal ganglia. Like the premotor area sends an extrapyramidal track to the basal ganglia. Now the basal ganglia tells the cortex. So it is a disorder of the extrapyramidal system itself. Pull test in Parkinson, I'll explain this today. Yeah, in new edition of Harrison, what we found was that the word relapsing has been, the remitting has been removed. It is just a relapsing type of MS. and about onset events, the four type which I showed you, is a single episode, right? So, but if you remember, RRMS is also correct. It's not wrong because some of the journal articles which I keep on reading, I still find the word RRMS over there. Are the inputs fixed for naming or repetition? For example, I see an object. The input comes from the visual cortex. I understand the object in Wernicke's. I make the word of the object in Broca's and tell out, right? While for repetition, the input will come in the auditory cortex because the patient has to repeat with me whatever I'm telling him. So look at the concept now. For the repetition part, the input will always come into the auditory area. But for the naming part, the input will always come in the visual cortex. Wheelchair sign of Quinn will do today, don't worry. What are tics? I'll also tell you that thing today. What are the high yields from neurology? Oh my god. There's nothing like high yield, it's only a misnomer, high yield things. So everything is important, but the point here is that you do not go into too much details of the things at your level. If you know the basics, it's more than sufficient. Okay. So I always recommend that you always stick on to the basics. What is drug of choice for the bout onset? The first episode. Okay. You treat the first episode with methylpred, no response, then go with plasmapheresis. But to be on a safer side, we found that the bout onset, that means a single episode, can relapse also. So it's always better to put them on a drug which is somewhere preventing the further relapses. So they do require DMR, disease modifying agents. Okay. Where do I find the neurology test? Is in the test series section. You can go and click there. It's very simple. 50 questions, 1 hour. You'll solve in just 25 minutes. It's very fast. Gait and cerebral palsy. Okay, I'll try to show this today. Okay, there's a scissoring gait for this. I'll try to cover it. Why can't the naming come from auditory? No, naming means I see a lot of objects in front of me, like a mobile phone. I want to pick it up. I will always see it. I'll not hear it. Okay, so mobile phone might ring. Okay, I know the sound of the mobile phone. But where is a mobile phone? The input is always coming in the visual cortex. As I said previously, nowadays my mobile phone doesn't ring because it starts coughing nowadays because it has got a lot of information about corona and COVID infection. So my mobile phone no more rings, it starts coughing. Okay. Scissoring gait, I'll show that video to you. I just missed it yesterday. Difference between decorticate, decerebrate. You'll cover this thing in somewhere your classes of physiology, that flexion of the upper limb and extension of the lower limb is a decorticate. Rigidity, extension of the upper limb with extension of the lower limb is a decerebrate. Remember this simple clue. Anything, a lesion involving the corticospinal, somewhere above the midbrain is a decorticate, somewhere below the midbrain is a decerebrate. Constant question coming, what is the drug of choice for PPMS and SPMS? I've already told you this in the last class. If you can go back into the notes either once. Okay, temporal arteritis blindness is not reversible. It's always preventable. Essential tremor video. Just imagine you are on a stage, you have to perform. You'll start shaking. But a friend of yours comes and offers you a drink, you become more calm and quiet now. Okay, so that's essential tremor. You can just imagine all these things. Put-off signs are signs in which there is exacerbation of symptom or exposure to heat, especially the visual symptoms. Fascinating gait occurs on walking, and the kinesia paradoxa typically occurs on running. Like a patient of Parkinson, whenever I see him walking very slowly, but whenever he is running for a bus or a train, he runs very, very fast. Okay. Drugs exacerbating myasthenia, I'll tell you today, don't worry. Yeah, SPMS, somewhere the pharma people do tell us there has been a trial that high doses of interferon beta versus mitoxantrone had a better effect. MOG antibodies. Now, what happens is there's a myelin oligodendrocyte glycoprotein against which the antibodies are actually fighting inside the myelin tissue. So we just need to remember there's an MOG antibody, but I'm not taking you to the MOG now because somewhere this year in NEET PG they asked a very direct question that what are the antibodies directing against them against what structure? It's always a myelin. Yeah, musk can be taken as a transmembrane protein. In the membrane across, it's there. Like a protein or an enzyme is there. What it takes, I'll tell you later. Today lecture will be till 9:30, but if you allow me, I can extend it a bit also, 10-15 minutes, that's fine. We are continuing with Parkinsonism part 2 today. West syndrome is infantile spasm. We cover this in peds. Some of the epilepsies are specific for the kids. Don't worry, you'll cover in peds. You'll see there once. Yeah, I'll explain the subtle motor signs in absence seizure are also some jerky movements in the hand. Okay. Question discussion, I'll take it at the end. Parkinsonism plus, I'll take it today. Okay. We're just 2 minutes away from starting. Any genuine doubts? How does fine tremor look like? This is very small fine tremors. So anytime a person is shaking the hand very fine, it's known as a fine tremor. Okay, some people have got a faster clock than me. Good. They say time ho gaya, start it. So, okay. Keep calm. Keep calm. It's the last day of the class, right? But somewhere a time of 7:30 p.m. or maybe a time when you want to do time pass, the Damsonian in the lockdown will always go for something to understand and read, that is e-medicos. There's always something in your life left to write. It's all your decision what to take in this lockdown. Just do time pass or study. Because I always feel this time is the most peaceful time when you can really study well. There's not much of hustle and buzz around you, no traffic at all, no stress of going anywhere else. Okay, right. So let's start it with the Parkinsonism. Let's continue with Parkinsonism, the clinical features of Parkinsonism. Clinical features of Parkinson disease that we know. Now, if you remember, Parkinson disease is well seen and with that mnemonic which I told you yesterday, known as TRAP, TROP. The word T stands for the word tremors. They were the resting tremors in the patient that we know. The R word standing for the word rigidity, that means a stiffness on a passive motion, resistance that you find. A stands for the akinesia word, that cannot move at all. And the last P that we'll discuss today onwards is the postural instability. Now the word is postural instability. What does it mean? Does it mean the person of Parkinson's sitting will fall down? No. Something we should know that in patients of Parkinsonism or Parkinson disease, there is loss of postural reflexes that we find. Okay, so there is a loss of postural reflexes in these patients that we come across with, which is known as the postural instability. Now, what does it really mean, postural instability? Let me explain this in a video. Like fascinating gait again. I was trying to walk, and now suddenly the last part, sorry, when I stopped on looking at an obstacle in front of me, I fell down. See, whenever you are walking and when you suddenly stop, will always be extending your spine, and in a way you can easily balance your body and not going to fall down. But this time when I saw an obstacle, at the last part of it, I just fell over the obstacle because I could not extend my spine. All the time I was stooped and flexed in this. So this is something new, something important to understand. In Parkinson patient, they got loss of postural reflexes. That means they happen to have a tendency of fall, especially on sudden stopping. So when the person is walking and he suddenly stops, they kind of fall onto the object in front of them, right? This is known as loss of postural reflexes. Correct. Now, how do you assess it in the clinics? Like, if such a person comes to me and I have to look for this kind of a thing, do I make the patient walk in my OPD and fall down? No, I'm not going to do that thing. What do? I stand behind the patient and pull him backwards. That is known as a term pull test. In the pull test, what do? We basically pull the patient backwards, okay, and the patient falls. You must be wondering why I'm telling all this, because if I pull you backwards by standing behind me, or rather you are in front of me and I'm standing behind you and I pull you backwards by holding you on a shoulder, will you come and fall over me? No, because you know I'm behind you. You'll always easily maintain your balance on sudden stopping. But this patient, just understand this, when I pull him backwards, he just comes and falls on me like a pole. So he goes and falls over me like a pole when I pull him backwards like this. That's the pull test. We look for the loss of postural reflexes by doing a pull test in the patient. Okay. A student asked me another doubt, sir, why didn't you do a push test to the patient? Because possibly you thought that the patient will come and fall over you. That means the patient comes and falls over you like a pole. So it might injure you. That means your patient is now injurious for your health. Why don't you do a push test? My dear friend, if you remember, if I push the patient, he'll apply the fast forward button and he'll run away from my OPD because he had one thing, what? Kinesia paradoxa, if you remember. So please remember, don't do a push test, do a pull test. By pulling the patient back, the patient falls over you like a pole. So don't do a push test because he is going to run away with a fast forward button, kinesia paradoxa. It's always better to do a pull test. Now, apart from this, few more motor symptoms that we find in these patients is micrographia. Okay. In micrographia, whenever the patient is writing, he writes a word or anything very, very small. Now, how does a micrographia look like? If I write it like this, I am a doctor. That's a classical sentence. Patient of mine with Parkinson disease, when I look at him, he's going to write this sentence like this. Yes. Now when he keeps on writing, his handwriting becomes smaller and smaller as he keeps on writing. So that's a typical doctor handwriting in an OPD slip also. Micrographia. Now the concept of micrographia is the handwriting is not small on the very first word. As he keeps on writing, progressively it becomes maybe invisible or very, very small. Just a comparison is that a patient of essential tremor has come to me. Essential tremor. If you remember the essential tremor. They write like this. Now look at the handwriting of a patient with essential tremor. Most of the time they write like this. They write comparatively very big to a normal person. So something that we read in the book, that in patients of essential tremor, they got a relatively large handwriting, So whenever they are writing, they write very, very big. Okay. I hope still you remember this. When you have written in your answer sheet on the last page, especially, your writing will be either micrographia or maybe essential tremor like. Okay, many people are telling me, yes, that's my handwriting, sir. Good. Now, there's another comparison drawn on this, that if a normal person has been asked to make a spiral, a normal person will always make a spiral like this. Now, that's a spiral. Okay. While in a Parkinson disease patient, when they make a spiral, they make it very small because they got a micrographia with them. While on the other spectrum, you can just imagine patients with essential tremors are going to make a spiral which is relatively very, very big. And above all, with a zigzag seen all throughout. So there was kind of a tremulence, which you remember the square that we made in essential tremor yesterday. So there was a tremor all across while making it. So these patients of essential tremor make a very big spiral with a lot of tremors coming in between while making it. Okay. Apart from this, don't forget that patients of Parkinson disease do speak with a tone in the speech which is not very high pitched. It's very low pitched sound, or maybe a typical soft voice in the speech. That is known as a term monotonous speech. So why does this monotonous speech happens? It occurs due to less phonation that we have known as hypophonia. So let me show this or make you hear the monotonous speech. For example, a patient with Parkinson disease will have a monotonous speech like this. If I talk like this, I am a doctor, right? This patient is going to spell the same thing like this. I'm a doctor. Don't worry, volume control is fine. He's having a very typical soft voice while speaking. His pitch of the sound is very low and is same throughout, as if he's whispering something into the patient's other person's ear. So that's a very typical monotonous speech, soft voice, due to less phonation that we had. Okay. If you remember some speech deficits, I've told you already. A patient comes and talks to me like this. That may be a jargon speech. A person talks like this. That may be, of course, a broken telegraphic speech. While on the other spectrum, a patient comes and talks like me this. I am a doctor. That was a scanning speech of cerebellar. So we got various kinds of speech patterns that you already know. Good. Along with the monotonous speech, these patients often have a face that doesn't change the expression so often. That is known as a typical mask-like face. Now, what is the word mask over here? When I look at some person, I always see some kind of expression that may be anxiety, depression, something like this. But this patient doesn't show much of expression, or if at all the expression is there, it's same throughout a long time, like a joker, mask-like face. Now, that is also known in the book as the word hypomimia. Doesn't show too much of expression, known as hypomimia. Now, I'm very sure you must have seen a mask-like face, especially on the face of your examiner, whenever you went for a viva. Yeah. So, if you remember the olden days when you went for viva, you wished the examiner, "Good morning, sir." The examiner looked at you and mentioned, "Good morning." Now, you gave some answer. The examiner again said, "Okay." So, you always talked with a very soft voice and a mask-like face. And while going away somewhere, if you see in the examiner, they always give marks with a very small letter written there, micrographia. Okay. So that's a typical mask-like face, hypomimia, that you should always remember. Apart from this, don't forget that these patients of Parkinson especially, they have got decrease in blinking. So they don't blink that much or too much like any other person. The blinking is comparatively less as compared to a normal subject. But we found a sign related to this, which has been recently asked as a clinical sign known as a Mersenne sign. Now, in the Mersenne sign, what do we elicit and what do we look for? When we tap on the patient over the forehead region, when we tap on the patient's forehead region, suddenly we find sustained blinking in these patients. So in these patients, we find sustained blinking, especially when we tap on the forehead. You can just try it from your side. If you tap on your forehead, you may not blink, you may just blink once. But if you blink continuously on tapping on the forehead, please visit the nearest doctor, okay? Because that's a sign, Mersenne sign, there is a sustained blinking on tapping on the forehead region that is seen in these patients. Apart from this, there are few non-motor symptoms also that we come across in patients of Parkinson. Like they have inability to smell anything which has been given to them, anosmia, okay? They cannot smell anything around, anosmia occurs. Apart from this, these patients typically suffer with depression and dementia. So they happen to see a memory loss, dementia, depression and anosmia. These are three, apart from the motor symptom, they can be a non-motor kind of a thing with patients of Parkinson. Now, do remember this simple fact and a clue that dementia occurs almost 1 year after the onset of the disease. So when the disease has come to me, almost 1 year after the onset of the disease, we find in these patients dementia comes into them. Okay. Now, there are a few questions that we need to add on to these basic things. In patients of Parkinson, remember this, in patients of Parkinson disease, I've told you earlier yesterday that one of the earliest symptoms they might come to me. The earliest symptom they might come to me is nothing but my tremor, which is unilateral and known as a resting tremor every time. Apart from this, that these patients have one of the most disabling symptom, and rather in the book given as a most essential symptom also. So in these patients we find that the most disabling and the most essential symptom to diagnose the disease is bradykinesia. That is a younger brother of akinesia known as bradykinesia. Okay, some people are telling, sir, I have done this and I'm having decreased blinking. That's normal. Normal. Even if I tap, I will not blink at all. That's normal. Okay, excessive blinking is abnormal. All is well. Don't worry. You don't suffer with any kind of a disease. Don't worry. Now, what is the reason behind all these non-motor symptoms, right? That's a genuine question. See, the Lewy body, which you remember, was in the substantia nigra region of the midbrain, affecting the nigrostriatal pathway that we discussed yesterday. It might happen that these Lewy body go into the olfactory system. Because of all these things, the olfaction is affected. Maybe it goes into a subcortical area where the memory circuit is made. So memory loss occurs into them, dementia. So all these things are quite interconnected. So the Lewy body might start to appear there, but later on it will know all the brain, all the different structures. Okay. Yeah, the taste remains normal. The smell is abnormal in them. What happens in these patients? What is the reason for Mersenne sign? Even I could not find any good reason behind this. This is just a chance that we find. Why anosmia occurs? Because in these patients that the olfactory system would have Lewy body deposition. Okay. Now what happens is this another very important clue. In Parkinson, remember this. The presentation of the disease is often unilateral. Remember this, or in a sense, I can just write the word asymmetrical. So that will be better. Don't write unilateral. That's a very wrong thing if I write it. It's better if I write it as asymmetrical. That means the disease, tremors, rigidity, and all these drama will happen on one side, not on both the sides. So it is written as asymmetrical kind of a thing. Okay. hypophonia occurs, so there is a kind of a resistance to speak also, because all these voice box and tongue muscles might have some kind of resistance to speak or articulate the speech. So there is bradykinesia not in the movement, but bradykinesia in the speech pattern also. Okay. Blinking always increases in Parkinson. There is a sustained blinking that we come across, Mersenne sign. Now let's move into another group of disease which mimic Parkinsonism but are not Parkinsonism. They are known as Parkinsonism plus or atypical Parkinsonism. Oh my god, some spam is typing first slide please, first slide please. Arre Baba. Tomorrow morning you can get up, you'll see the video, you can download it, you can see the first slide there. Why so the first slide dikha do? Do you go to a movie theater and say, tell me that I missed the first scene, please show me again? No, you paid them money, you asked them? No. Logics. You'll go to the movie on time, you'll catch the flight on time, train on time, but class never on time. Decreased blinking is a normal thing. Decreased blinking is a normal thing. Increased blinking is a abnormal thing. Micrographia, Mersenne sign. Right. Parkinsonism plus atypical Parkinsonism. See, it's a very common habit to go to something that it is late. If you go for your marriage late, your groom will run away. The Pandit ji, everyone will run away and remain bachelor all throughout your life. So practice to be on time all the time. Okay. Parkinsonism or atypical Parkinsonism. Now there are few disorders into this list. Number one is progressive supranuclear palsy. PSP is the abbreviated name for that, PSP. Also well known to me as a Steele-Richardson syndrome, but I'll not use the term here. What are the things which are different here now? Okay, I'll go to the concept later on of differentiating them. But remember what happens in a patient with PSP. Okay, the PSP patients happen to have, while walking specifically, not a stooped or a flexed posture, a typical extended posture. Okay, so while walking, a Parkinson, if you remember, was always stooped and flexed, but this one is an extended type of a thing. Second important thing that they have is a defective downward gaze. So when they look down, they cannot look down so easily. So just imagine this. What happens is that when they cannot look down, they have got a consistent history of fall suddenly. So when the person cannot look down, defective downward gaze, they will easily fall down by hitting an obstacle on the ground. That happens in these patients. Apart from this, remember this, these also have got dementia as a symptom with them. But most of the patients of PSP disorder don't have tremors as a symptom. So tremor is something which is typically missing in these patients. Okay. Right. Now I'll tell you one more fact. Just forgot to tell all this thing. I'll tell you one more fact. Write it here in Parkinson. You know, in Parkinson disease patient, what do you find? Postural instability as a problem. The postural instability as a problem usually happens in the advanced stages of the disorder. That means the disease has gone too far off from the onset in number of days and years. The postural instability occurs maybe in the last. That's why I've given you a mnemonic like this, you know, TRAP. The relevance of the mnemonic is this: tremor happens to be the first and the P word, the postural instability, comes on the last. Okay, so one which we happen to see is advanced stages. That means the disease has progressed too far off from the onset. Then you come across with a postural instability. Now you can just connect it clinically, like a patient of postural instability will always have recurrent history of fall. And don't forget, fall occurs in patients of Parkinson quite late in the disease. If you can connect all these things. What happens is suddenly a patient of Parkinson is walking, he sees an obstacle on the ground and falls down. But all these things and problems will come quite late in the disease. So postural instability is not an early feature of Parkinson, it occurs in the advanced stages. So history of fall in Parkinson is comparatively late. Okay, now apply this. In patients of PSP, history of fall, if I look at, occurs most commonly due to defective downward gaze. So history of fall will very often be early in these patients as compared to a patient of Parkinson. Okay, as compared to a patient of Parkinson. Now I'll show a video which I've recorded again to explain this PSP kind of a disease. How does it clinically look like? First of all, a patient of Parkinson as compared to a patient of PSP as compared to Parkinson will always have an extended posture, not a stooped and a flexed posture. Okay. Secondly, when they're walking all the time, they don't look down. They got a defective downward gaze. So they keep on walking. Oh, they don't see the obstacle and suddenly fall down. Extended posture, defective downward gaze, don't see the obstacle and suddenly fall down. So that's a typical patient of PSP. Okay, progressive supranuclear palsy. History of fall due to defective downward gaze that we find. Now, there are two types of PSP that we come across with. You'll not find all these videos on eMedicos. Some of the videos I have not put on eMedico. It doesn't make any sense because they're connected with the topic. Okay, so you can see this, you can see it once and same. Okay, someone is riding, my baby has the same car. Yeah, my kid also has the same car. They name it as Ferrari. That's why I feel very rich in my house. But I've got two kids. If you got one kid, you're parent. If you got two kids, you become referee. Now, there are two types of PSP that we come across with. Remember this. In PSP, there are two types of PSP that we come across with. One is a PSPP and the second one is a PSPR. Now, why did I put it under two headings? Because the word P stands for Parkinsonism. So there is a Parkinsonism form that we find. That means it often resembles, now that's an important thing, PSP type often resembles Parkinsonism in early stages. So in the early stages of the disorder, it often resembles Parkinsonism patient. And a very important thing, it often responds. It often responds to levodopa. So when you give a levodopa drug, I'll come to that concept, how does levodopa work and all these things. So all these things, remember, they might respond to levodopa, they might resemble Parkinson in the early stage. So that the word P comes for the Parkinsonism form. Now the word R, now this on the other side, if you look at PSPR, what does it stand for? It is known as a Richardson form, That's why if you come and read somewhere else this very topic, PSP is also well written as a Steele-Richardson syndrome. Okay, so whatever I've talked above till now, the extended posture, defective downward gaze, history of recurrent fall by hitting an obstacle, everything is a PSPR type. Now what's the difference? One thing, very important thing, that these patients are often unresponsive to the levodopa therapy, right? Okay. Now why Parkinsonism plus is kept separate? Look at them. Parkinson patient had a stoop flex posture. PSP wala had an extended posture. He had a defective downward gaze. Because of it, he cannot look at the floor, hits the obstacle and easily falls down. Okay, so it's a plus type, some extra thing and some different thing, atypical type. So whenever we try to discuss PSP, progressive supranuclear palsy, it always comes under the heading of Steele-Richardson, that is a typical Richardson form. They do not respond to the levodopa. Okay. Second thing. Second type of plus. So you can easily tell me the difference between PSP and Parkinson. Parkinson patient was flexed, PSP vela is extended. Parkinson never had a defective downward gaze, they have it. Both of them have a fall. History of fall in PSP is quite early, history of fall in Parkinson is comparatively late. Tremors are first thing to be seen in Parkinson, tremors are not seen in patients of PSP. While the PSP with Parkinson now, that's difficult to easily differentiate because they resemble Parkinson or maybe a simple Parkinson disease in an early stage. It's very difficult. Second type. Second type that we have is Lewy body dementia. Lewy body dementia. Okay. Being abbreviated as a word LBD. Yeah, P can change to R type, no doubt. Okay. PSPP initially might have a flex posture, later on it becomes extended. What is the pathogenesis here? I'll just tell a brief about it at the end. When I complete all these types, I'll tell you some bit of pathogenesis. Why is it so different? Now, Lewy body dementia is a mighty important topic. This has been asked n number of times in all the exams. Now, what is Lewy body dementia? These are patients of Parkinsonism kind of symptoms who usually present to me with a lot of visual hallucinations and of course have got dementia with them. But dementia, if you remember, in Parkinson happened almost 1 year after the onset, while in patients of Lewy body dementia is less than 1 year of onset. So in LBD patients, we find dementia occurs in less than 1 year of onset. In Parkinson, it happened more than 1 year of onset. So something extra now we have is a visual hallucination with a early onset dementia. You can write the term as early onset dementia. Okay. Right. Apart from this, number 3. Is another very important type that is known as a multiple system atrophy. Multiple system atrophy that we know, being abbreviated to me as our MSA. Now, what is the meaning of the term atrophy? You know, this is degeneration, but it's multiple system. Multiple systems are degenerated in the patient. Now, there are two types of MSA that we clearly see. One is the MSA, you can use the word A, and the second one is the MSA C. Now, what is the word A standing for here and what is the word C standing here for? Right. Now, the word A stands for the word autonomic. MSA A means a patient of Parkinsonism who comes to me with a lot of autonomic instability. Right. While the MSA C means a Parkinsonism patient who often comes to me with a lot of cerebellar symptoms. Now find these words out very correctly, that the word A stands for autonomic instability, orthostatic hypotension, reflex tachy brady on changing posture, or maybe cerebellar symptoms. Can be an intentional tremor coming in with a different cerebellar symptom that you know. So the word C stands for cerebellar, A stands for autonomic. So the atrophy is not only in the substantia nigra, it happens in the autonomic chain, it can happen in the cerebellar area also. Okay. So number 4 now is corticobasilar degeneration. corticobasilar degeneration that we come across, being abbreviated as a word CBD. CBD is a patient of Parkinsonism-like features who comes to me with dystonia, right? With myoclonus and of course dementia or memory loss that you know. Now what is the meaning of these words dystonia if you remember? Dystonia means actually sustained posturing. That the person limb or a part of the body is there for a very long time is known as dystonia. Myoclonus. Myoclonus means a typical jerky movement. So sustained posturing is dystonia. Jerky movement is myoclonus that we have seen earlier, and memory loss occurs in them. Apart from this, there is another interesting sign or clinical symptom seen in them known as the alien limb phenomena. The word alien, that means is someone not from our planet, someone from away, from a different planet who is not like me, is taking away my limb. Okay, alien limb phenomena. Now what happens in alien limb phenomena? There is unintentional limb movement that you find. That means a person takes up the limb on his own without planning about this. Okay, it's known as the alien limb phenomena. Phantom limb is something different. Okay, phantom limb is something different. Okay, I'll just show a video which I can explain all these things into one video. What is dystonia, what is myoclonus, and most important, how does the alien limb behave? Like this. The upper limb of my right side is constantly in this kind of a posture. That is a sustained posture that we find. That is known as dystonia. Suddenly, it might jerk also intermittently. That is a myoclonus that I could not record so well. But apart from this, suddenly this right upper limb, I'm looking at someone or talking to someone, the right upper limb will suddenly go up. And I'll look at it and get surprised. And I'll use my left hand to pull it down. It seems that my upper limb or especially the hand is being captured by someone else. Okay, some alien or jadoo has come from some other planet, is taking it away. So I'm pulling it back. So this is a sort of a unintentional movement of the limb that you happen to see, and the person becomes quite aware of it later on and takes out his normal side to pull it back. Okay, so that is known as a alien limb phenomena. Okay, so just remember these, don't go into details of all these things. Why does it happen at your level? It's too hi-fi to understand, but just remember the clinical symptoms. That's more than sufficient. Okay, CBD, MSA, LBD and PSP are four types of Parkinsonism which are not Parkinsonism. They are different, they are atypical, and always they've got something extra with them known as plus. Now don't forget to write this line that the presentation in patients of Parkinsonism plus can be symmetrical. That means Parkinson disease idiopathic that we were just reading now was asymmetrical. This happens to be equal on both the sides, can be symmetrical. Most of these patients, remember this, most of these patients are found unresponsive to the wonder drug that we use for therapy in Parkinson known as levodopa. So most of these patients are unresponsive to levodopa. Okay, all these signs, hummingbird, hot crossbun appearance, MRI changes, everything you'll better read in your radio classes. I don't want to mix up too many facts into your notes. Okay, now someone was asking me why does all this drama happen. See, if you remember what we were starting yesterday in Parkinson, we had a body which was known as a Lewy body. You remember, right? Lewy body, which contained a substance inside it known as alpha-synuclein. So what you find in these patients as a disease known as synucleinopathies. Okay. So there are disorders which carry alpha-synuclein with them, Lewy body. They are known as these synucleinopathies. Just parallel to this, if you ever read in systemic path, you come across these proteins there known as a tau protein. So tau proteins causing neurodegeneration, all those disorders are kept together into one roof as taupathies. So if you come across taupathies anytime, remember this is Alzheimer's disease. So Alzheimer's disease is a perfect example of a disease which carry a tau protein, taupathies. Sorry. Now Lewy body. Lewy body is something which have the alpha-synuclein within them. What are those disorders which carry Lewy body? Parkinson disease, one of the classical example. Apart from this, there can be a disease that we just now read, Lewy body dementia. Some fugax is happening, don't worry, it will be fine. Lewy body dementia, okay? Lewy body dementia, don't worry, it will be back, it will be fine. Lewy body dementia. And the third disease that we find in the list, which can carry a synuclein over it, is MSA. Multiple system atrophy is another example for it. Taupathies. Okay. Taupathies is something which happen in Alzheimer, one thing. Another disease is PSP and another disease is CBD. So, corticobasilar degeneration, progressive supranuclear palsy and Alzheimer, taupathies, Lewy body, synucleinopathies, Parkinson, Lewy body dementia and multiple system atrophy. So we find different kind of things into the brain which can cause degeneration. So don't forget these two names, synucleinopathy and taupathies. Okay. Yeah, in CBD if it is symmetrical then both should go up. No. Actually the CBD happens to be one thing which can be asymmetrical also. CBD, are baba, corticobasilar degeneration, not common bile duct. Okay, PSP, progressive supranuclear palsy. Great people. You have got such a short attention span as well as memory span both. Now, someone was asking me one genuine doubt, so what is Shy-Drager syndrome? Yeah. Because I'm seeing your comments, most of you have become Raji Masant. You don't like the class, you type. It's boring. It's taking too long. You're giving me stars also. So all the Raji Masants in the batch, keep quiet. Okay. तुम्हारा बाप हूँ मैं. Now, this one. A. MSA. Okay, A. Autonomic instability. If at all occurs, is also known to me by a different old name known as Shy-Drager syndrome. So there's a term known as Shy-Drager syndrome. Now this is something which we know as Shy-Drager syndrome. That was a very old term, I remember, in which Parkinsonism with autonomic instability in the older books was always referred as a term Shy-Drager syndrome. Right? Okay, please louder. My throat is bad today actually. Now let's move into the treatment part of Parkinson. Okay, good. If levodopa is at all given, it might aggravate. Yes, sometimes it increases the dopamine and can cause psychosis and all the psychiatric symptoms. No, hemiballism is something different. Hemiballism means the limb just shakes. It's not alien limb. Okay. Now, Parkinson disease is something that we need to understand the treatment part. Why the name Shy-Drager? Even I don't know this. Okay. Why the name Shy-Drager? It might be some connection with the patient or the doctor's name. Okay. Right. Now we find two things with us, that in Parkinson there is decrease of dopamine centrally and increase of acetylcholine. Okay. dopamine decreases and the acetylcholine increases. These are the two things that happen parallel to one another. Remember, this dopa and acetylcholine are always antagonists to each other, right? So dopamine decreases, the acetylcholine relatively increases. Now what happens in these patients? A normal dopamine level that I see could be 100%, while in patients with Parkinson disease, it becomes 70%. So there is a decline in the level of dopamine by a magnitude of almost 30%. So what you find that the dopamine level in the brain goes down. That's an important thing. In patients of Parkinson, most of the time, the dopamine level often goes down. From a normal level of 100%, it goes to 70%. That means there is a decline of a magnitude of almost 30% in the level of dopamine. Now, what does the dopamine level goes down and causes in me? Can you tell me, please? We have discussed concepts yesterday about this. It is going to result with rigidity and of course bradykinesia. So bradykinesia, rigidity is something which can clinically happen due to this thing. Now, acetylcholine rises. What would happen in the patient? Someone was asking me what is the reason of tremors in Parkinson. There's some black, don't worry. Tremor happens most of the time in Parkinson due to increase of acetylcholine. So suddenly the acetylcholine in the brain centrally increases, that results in tremors. Dopamine level goes down, that causes bradykinesia. So two things happen parallel. Well, I'm telling the story because not antagonist in a sense or clinical way. Whenever dopamine comes down, the relative rise of acetylcholine happens. It's not that antagonist to think about. What is the investigation of Parkinson disease? Okay, I'll ask you this question, don't worry. That's a very interesting question. What are the investigations? Baba, you're not writing some short note or long note, investigation and then treatment. Okay, I'll come to the investigation part. First thing, remember this somewhere that you have ever read in pharmacology also. Levodopa. Levodopa is something that is very helpful in patients of Parkinson, right? Now, how does levodopa work? If you remember, you give levodopa to the patient, right? And very important thing is blood-brain barrier. It crosses a barrier between the brain and the blood very easily. It will convert to dopamine, I agree, or it might stimulate a central dopamine receptor. Now pay attention to this small concept. Now I have a patient who I have given a drug which is a prodrug of dopamine known as levodopa, which can easily cross the blood-brain barrier, enter the central nervous system, okay, and can stimulate the dopamine receptor or convert itself into there, right? Now what will happen? There are two patients with me of Parkinson. One in whom the dopamine level is low and another patient in whom the dopamine level is normal, correct? Find this out. If a patient of dopamine level in the brain low, when I look at this, rigidity and bradykinesia. If the dopamine level in the brain is low, what will happen? Rigidity will occur with bradykinesia. That's correct. But when the dopamine level turns to normal, will they have rigidity and bradykinesia? No. So I'm writing the word minus over here. So look at this patient. A patient of Parkinson whose dopamine level is low, is he taking a levodopa tablet? No. A patient of Parkinson who's having a normal level of dopamine has taken a tablet of levodopa. Correct? Now find this out. The dopamine level is low or the dopamine level is normal. How does the dopamine level when normal? When the patient takes a tablet of levodopa. His rigidity and bradykinesia clinically is almost absent. Now what happens is a patient of rigidity and bradykinesia, is very stiff, he cannot move around. So he's off, correct? While a patient without rigidity and bradykinesia comparatively is on. So a patient of Parkinson who doesn't suffer with rigidity and bradykinesia is on. He's on a levodopa tablet. He's on. While a patient of Parkinson who is not on the levodopa therapy is having rigidity and bradykinesia, he is off. Yes, some people are typing it right. Can you tell me what comes first? On comes first or the off comes first? Yes, on off phenomena. It's always written like this. There are a lot of explanation with the pharma people also tell me about this, but I'll tell you one clinical implication here. The levodopa in the peripheral, that means outside the blood-brain barrier if I look at, is converted to dopamine by the help of an enzyme known as decarboxylase. The peripheral decarboxylase enzyme. Now what happens, this dopamine which is peripheral cannot cross the blood-brain barrier. That's the problem. The levodopa is converted by the enzyme decarboxylase into dopa, and unfortunately it cannot cross the blood-brain barrier. Now find this out. It's very simple. The patient on levodopa therapy, the levodopa crosses the blood-brain barrier, he is on. But the levodopa now is converted to dopamine by decarboxylase and it cannot cross the blood-brain barrier. That means the patient becomes off. So my concept here is, if there's an on-off phenomena which occurs, my aim of therapy should not always be to bring the patient into on. My aim of therapy should also to prevent the patient from something which I know as off. How do I take care of this? A lot of drugs that you guys are telling me, good. One, I can inhibit this enzyme. The name of the drug is what? Peripheral decarboxylase. Okay. Peripheral decarboxylase inhibitor. Some people are telling me names of that drug. One drug that is known as carbidopa and the other drug that we know as benserazide. So these are the two drugs which are peripheral decarboxylase inhibitor. They will always help me to build up a good levodopa level so that it can easily cross the blood-brain barrier. So I can inhibit this on-off phenomena by giving this drug, peripheral decarboxylase inhibitor. Now what happens? Another thing. There are more than this enzymes. There's another enzyme with us known as the MAO-B enzyme, which can further degrade all these molecules. So you can inhibit that enzyme. I'm not going into the pharmac part for it. Two drugs again, siligilin and risegilin. Now remember, these two drugs happen to have a neuroprotective role. Most of the books in pharmac and medicine, maybe an initial therapy nowadays we start in an early Parkinson patient can be a MAO-B inhibitor also. Can't get the on-off effect right. Okay, I'll explain like this. If you got electricity in your house, the switch which is on will always glow. It's on. But if there is no electricity, it's all dark, it will be off. Correct? So it's like this. The electrical impulse for a patient of Parkinson to brighten him and move around is a levodopa. My patient of Parkinson takes a tablet of levodopa. Correct? Levodopa crosses the blood-brain barrier, stimulates the central dopamine receptor. Now the rigidity and bradykinesia that was due to fall in the level of dopamine goes away from the patient. That means the electricity is there. He's having a good voltage. There is no black screen in his house like yours. He is on. Correct? Now suddenly what happens? There is some voltage fluctuation. There is some poor Wi-Fi connection at my end or your end, and our internet suddenly breaks down. That means the electricity has come from a source, or the signal has come from a source, but suddenly on the way someone took away my data. Correct? So what happens now? The levodopa which was going to the brain peripherally is converted by the enzyme decarboxylase to dopamine. This dopamine molecule cannot cross the blood-brain barrier. Now what happens? The dopamine level in the brain falls down. I don't get the good internet speed and a black screen comes in front of me. If the black screen comes in front of me, I'm rigid. I cannot move. I'm off now. So levodopa, if the patient is taking in, he's on. If the effect of levodopa is going away, the patient is off. The on-off phenomena, that's very simple. To inhibit it, Peripheral decarboxylase enzyme, good. MAO-B inhibitors, they will really help me. Number 4, C-orthomethyl transferase inhibitor. Two more drugs, entacapone and tolcapone. Sorry. Entacapone, tolcapone are the two drugs that we have with us which can be given to the patient as a COMT inhibitor. Number 5. Oh, some few gags, don't panic. Number 5 is an old drug which was an antiviral agent known as amantadine. Now, amantadine is a drug which can indirectly increase the dopamine level in the brain. Now, that was a query by a student also, that what happens is that the amantadine is an antiviral. How does it work here? It tries to increase the dopamine level in the brain. Okay. Yeah, I know pharma people tell on-off phenomenon in a different way. Arey Baba, it's a very logical thing. It's not always the degeneration of the central neurons. Got my point? It's not always the degeneration of central neuron. Go with my concept. It's more valid. In my blood, there's a decarboxylase enzyme which can eat it away. So even in the early stages of Parkinson, not in the late stages, I have seen patients. It's a clinical concept. You go to your OPD, you start prescribing only levodopa. Patient after an hour of therapy will just go back to the bad thing. See, the point here is we always have to add a carbidopa with the levodopa. Otherwise, this thing will come quite early in the disease. Okay. Okay. Few of the drugs are not used. Tolcapone, I agree. I'm just mentioning the names. You can read it in details in Pharmac. Number 6 is dopamine agonist that we have. Right. Now, what we have here is a dopamine agonist. Few names which you know is ropinirole. Second is rotigotine. And the third one is an old drug that is pramipexole. So these are the 3 drugs which are central dopamine agonists that we use in them. Rotigotine happens to be available to me in a form of a patch. That means stick a patch to the patient, it delivers the drug constantly. It comes through the transdermal route. Rotigotine. Although nowadays in clinical practice we are not using it too much, but for theoretical purpose you should always know it. Number 7. Something which has come into the market in India recently, and I expect something will come on this, is apomorphine. Is it morphine? No. Is it morphine? No. It is a non-opioid agent. It's nothing to do with morphine actually. It's a non-opioid drug. But why the name apomorphine was given to it? Because it was a central dopamine agonist now. But the only big thing about apomorphine that I have is that it's injectable. Now it's injectable agent. Yeah, it might have a thing which I understand as emetic effect, great, but the central dopamine agonist effect is there. It's often injectable and it's a non-opioid kind of a thing. What happens is now a patient of Parkinson is in off. Correct? He wants to come to a stage of on. What do? I give him a drug like levodopa or dopamine agonist. I know this thing. Drugs are oral tablets. Oral tablets take their own sweet time. That means for a longer time they will have the action. Agreed. But actually the onset of action happens to be quite delayed. So I'm not writing the correct thing here. It's not should be more duration. The onset of action is delayed by oral tablet. But compare it now. On the other spectrum, there's a patient of Parkinson who is stiff, rigid, akinetic, off. I want to bring him to on. What do I give? I give him what? Injectable. Injectables are more bioavailable. They will be faster acting. Okay. For example, you are in the classroom sleepy. I keep on talking to you, right? So that's levodopa, dopamine agonist. My motivation thing will come to you quite late. But suddenly in sleeping, I crack a joke. You'll obviously get up because that crosses your blood brain faster, or maybe as compared to the motivation or the content. So jokes are like apomorphine for you in the classroom. They are non-opioid, they are central dopamine agonists, and they are faster acting. What happens now? Just imagine this. Off the patient is there, and I bring him to on. That happened very fast. Like the patient got saved from that particular situation. Rescue therapy, rescue therapy. So I rescued the patient out from a very bad problem off to become him on. Rescue therapy. Like Sanjeevani Booty, right? If you remember Sanjeevani Booty, you sing Ramayana nowadays, which Hanumanji bought for Lord Lakshman. Good. It can be a KBC question, you should know it. That was a joke. That was not a joke. So please do remember, rescue therapy is a thing that we apply here for, these are routine jokes, no problem. So rescue therapy happens to be something which is saving the patient instantly, okay? Now we have this one, increase of acetylcholine tremors. Now how do we treat such patients? Okay, some intelligent student has asked me, some methyl dopa is considered to be a dopamine depleter. Okay, it becomes a dopamine depleter. It is having dopamine inside it. If I give methyl dopa, it should increase the central dopamine level. Good question. Now find this out. What happens is there is a decarboxylase enzyme with me, correct? There is a methyl dopa with me, and there is dopamine with me. So now what happens, somewhere we find that whenever the methyl dopa hits the decarboxylase enzyme, the decarboxylase really gets confused somewhere. Where is my dopa and where is methyl dopa? So decarboxylase often attaches to the dopamine molecule very fast now, and it tries to degrade that also, even in the sense that it can degrade the levodopa to the dopamine level. So where we find, somewhere you can go back in pharma and read it again, that methyl dopa tries to mimic the dopamine molecule and tries to act on the enzymes which are trying to degrade out the dopamine molecule, and it tries to activate those enzymes, further causing the depletion in the level of dopamine, which is normal. Okay, you can go back and pharma read this again. Tremors. Whenever you have tremors, what do you have? Increase in acetylcholine. Are treated well, you give a drug which is known as anticholinergics. Now, when I look at the anticholinergics, one drug that I have with me is trihexyphenidyl. So don't forget, trihexyphenidyl is a drug which is a centrally acting anticholinergic agent that we use in them. Okay. So remember, in Parkinson, when we consider tremors as some problem and the treatment for tremor is not a beta blocker or anything, it's a trihexyphenidyl. Right. Now this is something important at the end that you should always know in any disorder. Propranolol and all doesn't work here. Drug of choice for Parkinson disease. If they ask you this question, what is a drug of choice for Parkinson disease? Remember this, don't hesitate to mark levodopa anytime. Now there are ifs and buts. In young people, they do recommend this as a dopamine agonist, but in an older patient, they recommend levodopa. Correct? So Parkinson in journal as a disorder, when I take it, it is always considered to be a disease in the elderly population, so they are more frequently affected than the younger ones. So when they don't mention the age part, please go with levodopa as a classical. Yeah, of course with carbidopa to add on. Okay. Okay. Now something extra that you will not be covering in pharmac is, when do you advise for surgery in patients of Parkinson? When do you advise for surgery in Parkinson disease patient? Okay, the concept of methyl dopa is like activating the decarboxylase enzyme, in a sense that, or any other enzyme which degrades on the dopamine. It tries to mimic it and tries to activate it. So whatever dopamine is there with me, it is going to go down with time. It happens to be like this. It happens to activate the enzyme which are dopamine depleters, which are going to eat away the dopamine, and the central dopamine level keeps on falling down, as well as peripheral also. Now, indication and what are the procedures that we follow? Two things that we know, one is the indication and one is the procedure that we follow. The very first thing in the indication that we have is intractable tremors. Remember this, the intractable tremors are something which are a very good indication for operating on a patient of Parkinson. Now, what is the meaning of the word intractable? That means we find this is a patient of Parkinson is having tremors, and in spite of the anticholinergic therapy, they are still there in the patient, in spite of treatment. We always use the word intractable for it, known as the word intractable tremors. Second one is drug-induced dyskinesia. Drug-induced dyskinesia is a term for it. Now remember this, you gave levodopa to a patient. It very well crosses the blood-brain barrier for me. It goes inside, and being a prodrug, it's going to convert itself into dopamine. Now what happens is the central dopamine level rises excessively. I was asking you yesterday, if the central dopamine level rises, please tell me again, what happens now? Direct pathway will work more or the indirect pathway? Something from the yesterday's class, direct or the indirect pathway? Of course, the direct pathway will work more. That means the stimulatory pathway will overpower the inhibitory pathway. Now, if the stimulatory power inhibits the indirect pathway, or when they overpass the indirect pathway, what will happen? Yes, you guys told me yesterday also, the moment which I have planned in my mind or the brain, that is going to go in a rapid way, hyperkinesia. Now find this name, drug-induced dyskinesia. Got my point? The drug is levodopa, but now it is causing some kind of a movement disorder, dyskinesia. So drug-induced dyskinesia is the term for it, hyperkinesia. Okay, so in a patient on levodopa therapy, we find worsening. So there is levodopa induced worsening that occurs in the patient. So you give levodopa to the patient, it induces worsening now. Worsening in a sense of movement disorders. Patient was initially maybe bradykinetic, and later on this therapy he becomes hyperkinetic. So everything went very worse because of the drug levodopa. Okay. Now what is the procedure what we follow here? Yeah, intractable and refractory means almost the same in this patient. There may be some spelling difference, but clinically they mean the same. Procedure. Procedure is the deep brain stimulation that we perform on these patients. Deep brain stimulation. Remember the name? Deep brain stimulation or the DBS. Now what happens in deep brain stimulation? Remember this. We stimulate the brain deep inside by some electrodes with the pacemaker attached somewhere outside. Remember this in subthalamic nucleus, STN if I look at. Just write this down. Deep brain stimulation of subthalamic nucleus is always done if the patient is suffering with an intractable tremor. If the patient is having drug-induced dyskinesia, we may go for deep brain stimulation of globus pallidus. Now you might ask me, sir, why this site is taken for this? Leave it. It's too hi-fi a thing to understand. Just remember two words. Deep brain stimulation of subthalamic nucleus is done if the patient of Parkinson is having intractable tremor. Deep brain stimulation of globus pallidus is done if the patient of Parkinson is having drug-induced dyskinesia. Okay. So these are the two things that you need to remember about. Drug-induced dyskinesia means the levodopa which I give converted to dopamine centrally, and increase in the level of dopamine causes hyperkinesia in the patient. Okay. There are certain drugs also, you read in pharma somewhere and psychiatry also. But in medicine, if a Parkinson patient comes with drug-induced or levodopa-induced worsening, we straight away advise them for a deep brain stimulation of globus pallidus. Okay. Intractable tremor means the tremors in Parkinson which are happening in spite of treatment. The word intractable is applied for them. You want some more gyan on this? Okay, it's GPI. Globus pallidus interna. Okay. Right. So the words on this, Maggie break is always required 2 minutes. Technical break, someone gave me a nice name for this, right? We'll take 2 minutes of break and come back, right? After this, we'll start the discussion of the test paper. You must have given test or not? Guys, you've given a test or not? You're given a test, good. Let's see how well have you given it, right? Some people are worried, where was the test given? These are those people who are more worried that the next month classes are 8 hours per day. They know that information, that the next month's classes are 8 hours per day, but they don't know where is the test given. Okay. Surgical procedure here is something in which we try to, in a sense, stimulate the brain deeply by a electrode with a pacemaker outside. That is well known as a deep brain stimulation. So deep brain stimulation is something that is done for either subthalamic nucleus or globus pallidus. Because I found somewhere in the Facebook that every 3-4 hours there is some student writing, sir, too many classes, 8 hours or 6 hours. See, you don't coin the 8 hours are together. We are separating them, and it's always wise if I try to cover 3 subjects in a day. It's good. And we are not teaching you very fast in these apps classes, and remember this. And take my words, I'm teaching more than the live classroom sessions. If someone of you has attended my live classroom sessions, they would have not got this much of data. Okay. So students, after solving the test paper, do tell me sang mala jo mala mahit nahi. Tell me something which I don't know. Right. So let me see how much you know. Okay. I got the paper with me. These are all easy questions. They are not hi-fi kind of things. Even if you have not attempted the test, koi baat nahi hai. Sit down with me for a few minutes or more and we'll try to solve it. These are just a revision. How much of CNS is left? This is more than sufficient for the live classes on e-medicos. The rest of the things, see, if I counted somewhere, I've done around 35% or 30% of my CNS, which I cover in the live classroom session. The rest of the things like stroke, spinal cord, Alzheimer, and some neuropathies and few myopathies we'll do in the live classroom. Okay. Now tell me something which I don't know. Motor manifestation of focal seizure is tonic, clonic, myoclonic, all of the above. Good. You guys know, remember this? It's not always a tonic. It cannot always be a clonic. It can always be not myoclonic. Can be either of them. One more thing which we saw in the videos was a tonic. Okay. So that's a very clear and very easy question. Now this one. Which of the following about a focal seizure with impaired awareness is false? What is incorrect about a patient of focal seizure with impaired awareness? It begins with aura. Behavioral arrest denotes the beginning of the ictal phase. Retrograde amnesia. Automatism. Can someone of you solve me this question? Focal seizure with impaired awareness is false. Now if you remember a few points about focal seizure with impaired awareness, what happened in the patient's life? If you remember. One thing I've chosen very clear, one thing which is seen classically in them is a sense of premonition, but not typical premonition. It can be hallucination known as aura. And suddenly, they will always have an ictal phase, which is not always a movement that you find. It can be a simple behavioral arrest in which the person loses the contact with the environment, right? In this ictal phase, remember this, the patient typically gives me a stare look. Along with this, in these patients, you might see certain kind of subtle motor signs known as automatism. Now, automatism was something which was seen in a lot of things. If you remember, subtle motor signs was seen where? Can you tell me now? Automatism is seen and automatism is not seen. There are two things that we have. If you remember, automatism is seen where? Subtle motor signs are seen where? Absence seizure, absence seizure. While automatism is not seen in one seizure disorder. Can you tell me one seizure disorder which doesn't come with automatism? No automatism is seen in them. It's not seizure, it's epileptic disorder. Yes, none other than my JME. Juvenile myoclonic epilepsy, doesn't have automatism. Absence seizure has automatism. Who else has automatism now? A patient of focal seizure with impaired awareness. He also has automatism with him in his life. And just to end it now, in these patients there is obviously a post-ictal confusion. Correct? There is always a post-ictal confusion that happens in them. So there are patients with me who have post-ictal confusion and patients who do not have post-ictal confusion. One patient who doesn't have post-ictal confusion anytime. All is well after the seizure was what? A patient of absence seizure. Don't forget him. One patient who had a post-ictal confusion. A lot of seizures. GTC has had a post-ictal confusion. Correct? Patient with focal seizure can have a post-ictal confusion. Correct. Now my question which someone asked on the Facebook also. A patient with temporal lobe epilepsy. Please tell me now. Temporal lobe epilepsy topic that we have covered separately. Will it have a post-ictal confusion or not? My question is this. A patient with a temporal lobe epilepsy, will they have a post-ictal confusion or not? Yes, if you remember, they had a focal seizure with impaired awareness as a presenting seizure. So someone was asking me, sir, where do you classify temporal lobe epilepsy? Do I classify it under generalized? No. I did discuss it in the continuation of JME and GTCS. But to be clinically correct on this, it's somewhere seen under the heading of focal. But we discussed it separately because of the different kind of treatment, which was surgery in them. Right? Simple. We also know this thing. Aura is seen, aura is not seen. I hope you remember this also. Aura is most of the time seen in focal seizure, often missing in patients with generalized seizure. Correct things. Now what happens is, just imagine this. At this dot the seizure started. Okay. When the seizure started, what happened with the patient for next 2 or 3 minutes? He doesn't remember it. We remember this term as loss of memory known as amnesia. Okay, there can be two kinds of amnesia. Like if I take this dot as a seizure, the onset of seizure, there can be two kinds of amnesia with me. One amnesia, I forget who am I, where am I living. That's a very simple term. I forget my past life, known as retrograde amnesia. When the seizure started, I don't remember what happened with me. It's known as anterograde amnesia. So look at this now. Seizure starts from the onset 2-3 minutes later. What happened with the patient? He doesn't remember that. That's known as anterograde. Maybe before the seizure, what happened in his past life, he doesn't remember that. That is retrograde. Like a patient of seizure recovers and ask him what is your name, he tells me correct. What is your residence address, Aadhaar card, phone number, everything he remembers. But what happened during the seizure, he doesn't remember that. What is that known as? Anterograde amnesia. So don't forget this term. Amnesia in patients of any seizure. When I want to classify, don't classify it as retrograde. In retrograde amnesia, the patient will forget his own identity. Who is he? Where is he living? He is having anterograde amnesia. Correct? Let me come back to the question and ask you now. Which of the following about focal seizure with impaired awareness is false? It begins with aura. That's true statement. Behavioral arrest denotes the beginning of the ictal phase. That's also correct. Automatism or subtle motor signs are seen. That's fine. Retrograde amnesia, no. It is often an anterograde amnesia that we see. Which of the following is false about typical absence seizure? Which of the following is false about the typical absence seizure? Now question number 3 with us. Main seizure type seen in 15 to 20% of children with epilepsy. That's a fact. You should know it. Yes. Small amplitude clonic movements of the hand is seen. Look at my hand now. My hand is shaking like this. Some jerky movement in the hand is occurring, which is continuous. Small amplitude, not big one. This is a part of automatism again. There are small amplitude clonic movement of the hand. This is a subtle motor sign that we find in these patients. Now, EEG discharge begins and ends abruptly on an abnormal background. Now, this is important. If you remember the patient of absence, they had a spike, yes. They had a wave, correct. But remember this, it comes and goes away. That means on either side, it is always a normal background on the EEG scene. That's an important statement. The normal EEG is coming, and when the patient hyperventilates, suddenly they get a spike and wave. Now, I can all connect this clinically. If you remember what happened before the seizure was what? Aura. What happened after the seizure? Post-ictal confusion. Correct? Did aura happen in patients of absence seizure? No. Did post-ictal confusion occur in them? No. So when the aura starts, there can be some EEG abnormality. Even in the post-ictal phase, you can have it. But these patients typically had a loss of contact with environment. For a very short time, if you remember the duration, which was classically less than 30 seconds. If you remember this topic, I've been stressing on this concept. Most of the time it was sudden in onset. It was a sudden onset loss of contact with environment. Okay. So do remember this fact. It always comes on an abnormal background. Okay. Sorry, a normal background, not abnormal. So this is one is somewhere incorrect statement. Now coming on to this, valproate is preferred when seen with JME. Now this is a catching thing. If you remember, drug of choice for absence seizure. Yes, drug of choice for absence seizure any time was the great drug ethosuximide. Ethosuximide. Correct? But drug of choice for juvenile myoclonic epilepsy was different. That was valproate. Valproate. Now we remember JME patients. They had myoclonus. Okay. If untreated, majority of them had GTCS. And 1/3 of them had absence seizure also. So 1/3 of the patient had absence seizure. Majority of these patients had GTCS. Now look at this. A patient with JME comes to me. 1/3 of them can have absence seizure also. But if I give them valproate, one drug will work on all the ends. It can be a drug for absence, it can be a drug for GTCS as well as myoclonus. Look at this now. One drug, many seizures are well controlled, right? So what we have in these patients, in absence seizure when they come in a case of JME mixed, please remember this. We don't give ethosuximide, valproate is sufficient for them. Although ethosuximide is favorite, no doubt, but in these cases, a broad spectrum valproate will always help them better. Okay, so that's also correct statement. While this one is an incorrect statement. Which of the following is true about epilepsy except? Easy question. Jacksonian epilepsy is spreading seizure activity. If you remember the dance Michael Jackson, Prabhudeva, yes. Serum levels of prolactin increasing dramatically after tonic-clonic convulsion. I was stressing on this. Serum prolactin is often high in a true seizure. Absence seizures are brief and more frequent. I have explained this also. Without post-ictal confusion. That's also correct. Changes in memory, perception and blackouts are not a feature of complex partial. Oh God. This is the old name for a focal dyscognitive. We have written that also. Changes in memory? Yes. They suffer with anterograde amnesia. Changes in perception? Yes, they don't know what's happening around them. And the blackout doesn't mean black vision. No, that's not the black screen. It means he doesn't remember what happened and he was not in contact with the people around him during that moment. This is an incorrect statement. That's right. They've written as not features. So they are features of it. Okay. Right. Look at this. Arrange the symptoms in a patient of GTCS from the occurrence of from beginning till the end of the episode. Why prolactin increases? I've explained this in the previous class also, that there was a pathway which was tearing down the dopamine, the tubuloinfundibular pathway. In a epileptic patient, that pathway is broken. So dopamine on the lactotrope doesn't come and there is an uninhibited rise of prolactin. Hanji. What do you have first? Remember, if you go with the GTCS, the premonitory symptoms, the abdominal pain, nausea, all these things happen first, followed by a tonic phase, which comes to me with the ictal cry, if you remember. Yes. Followed by what? A clonic phase. Followed by a post-ictal phase, that is urinary incontinence. So where do I go? Who came first? Premonitory. After that the ictal cry 2. Then came the clonic. And then this. Correct answer. These are the questions that we find in AIIMS. Arrange the things in an ascending or descending order of frequency or something like this. They are much easier than any other question. Remember this. If you know the first and the last one, you can easily guess the correct answer. But I was very clever here. I kept the option C also same as this. Okay. So they say no, chronology samajhiye. It's a premonitory symptom, tonic, clonic and urinary incontinence. Chronology. Okay. Question number 6. A patient with a family history of seizure disorder or anti-epileptic drug for the last 2 years, GTC is idiopathic, is seizure free since initiation of therapy. Presently the EEG of the patient is normal. What is the next line in management? If you remember, we have discussed this also in the very first class. Yes. If at all, any time a family history is present, it's always better to continue the anti-epileptic agent. Because if the family history is positive, the cause is genetic. And the chances of reoccurrence is very, very high in these patients. Right? It's very clear thing. Because this is something given in Harrison, the latest editions only. Now this one. This is another interesting question. 16-year-old male with a family history of seizure disorder complains of sudden jerky movement in both the upper limb on awakening. Sudden jerky movement on both the upper limb on awakening after a disturbed overnight sleep. That typically explains one thing to me, myoclonus, which often precipitated on one thing which I know as fatigue. A disturbed overnight sleep next day will give me a hangover, like a fatigue thing. He also suffers 2 episodes of GTCS now, and multiple episodes of staring look on running a short distance. Now look at this. The absence seizure that we always saw was often precipitated by hyperventilation. So increase in the respiratory rate often precipitated that thing. So everything comes under one roof. Yes, a juvenile patient, 16-year-old with a family history. Juvenile patient with many epilepsies, JME, yes. It has a polygenic cause, many genes are there, yes. Neuroimaging is normal, correct. Phenytoin is contraindicated, yes. With carbazepine also, if you remember, they exacerbate the myoclonus. Complete remission is common? No. That means on their own they will get alright. Complete remission. No, no, no. Lifelong therapy. If you remember my words, lifelong therapy in these patients is required of anti-epileptic. So complete remission is uncommon in them. They require valproate or whatever drug lifelong. Okay. So that's a very simple correct statement, but it's a mixture of many things. Now question number 8 is very interesting. See, all these questions are my experiences in wards, clinics that I've seen patients, and for the last 4-5 days I've been very regular on Facebook. So I was just reading all your ideas on all these things, so just made this all out. Now this one, 14-year-old boy with no past medical history has come with a cut wound over his forearm while playing with a knife. Now, first of all, a 14-year-old boy in this lockdown period is playing with a knife. What is he doing at home? He's trying to become a master chef contestant, or he's from Wasipur, perpendicular, definite, those kind of people. Okay. Now he has given tramadol injection, IV, followed by the stitching of the wound. Now we gave IV tramadol to the patient, and then we started stitching the forearm wound. Now this is important, not any scalp injury. Immediately after the procedure, he had an episode of witness GTCS. Oh my God. Which of the following is the next best step in management? Load the patient with an anti-epileptic agent. Advice for a CT scan to rule out head injury because he was playing with a knife. Wait and watch as it's a provoked seizure. Advice prolactin because it's a pseudo seizure. He's a 14-year-old. He's doing a drama. No. Wait and watch as the provoked seizure. Everyone is answering it correct because tramadol, if you remember, we have discussed in the first class itself, was a provoking or a precipitating event for these kinds of things. Correct? Don't think prolactin, please. Some people are answering me D. No, Waba. It's not a pseudo seizure. Okay? Think about tramadol provoking this seizure and just wait and watch. It will settle on its own. Correct. A pregnant lady who was on phenytoin should be given the following advice except folate supplement. Yes. Now a student came back, sir, neural tube defect. Somewhere you told us in the previous class was valproate. Why phenytoin will cause neural tube defect? Why do I require folic acid to him? Now remember this, neural tube defect is more commonly seen with valproate, but could also occur in two more drugs, VPC. The P stands for the phenytoin and C stands for what? Carbazepine. So these are the three drugs that we have with us. So folate supplement is again required to take care of this neural tube defect. Now vitamin K supplement, if you remember somewhere in pharmac you do discuss this, that phenytoin causes some reversible deficiency of vitamin K, not only in the mother but in the neonate intrauterine also. So it's always mandatory to start the mother in the last 2 weeks of pregnancy to on a vitamin K supplement oral, and of course as a protocol goes, always give a vitamin K injectable to the newborn also. Antenatal ultrasound for cleft lip and cardiac defects, of course, if you remember the fetal hydantoin syndrome, it's very important. Never change the anti-epileptic agent. Never ever change it. Let it be whatever she is on the lowest effective dose, because although phenytoin causes a problem, but the chances are not that frequent. Now this one is an interesting question. Another typical question that you find in AIMS again. Assertion and reasoning. Injectable phenytoin is never mixed in a glucose containing solution. A. Reason. Phenytoin causes hyperglycemia. Is that the reason? No, if you remember the first class, you guys only told me, sir, phenytoin precipitates in glucose solution. That's why it is never mixed. But phenytoin causes hyperglycemia is also correct. Now look at this now. Have an eye on this. Both A and R are true. In a sense, individually these statements are true. But R is not the correct explanation for A. Remember these questions asked in AIMS is a very famous one. Don't mark A is true, R is false. No. Read option B also. A and R are individually correct statement. Phenytoin causes hyperglycemia is a true statement. Injectable phenytoin is never mixed in a glucose containing solution is also a true statement. Why? Because phenytoin precipitates in glucose. Hyperglycemia is not the correct reason for it. Okay. Now this one. Syncope and seizure. Two sides of the same coin and the patient is tossing over it. Which of the following feature is helpful in differentiating syncope from seizure? Except. That means what is common between the two? The question is asking me what is common between the two. If you try to read it in a different way, what is common between the two now? Let me show this a table, because this thing we have actually not discussed in that session. So I kept it reserved for the further discussion. Simple concepts. How do you differ seizure from syncope? Make a table in front of you. It will be always better if you draw it and make it on your own once. If you remember, immediate precipitating factor for seizure. I'm not using hypoglycemia or hyperventilation here now. Okay. Immediate precipitating factor is usually not for seizure disorder. While syncope, yes. Emotional stress, valsalva, like I was trying to breathe rapidly or I was trying to hold a breath, is often seen in a syncopal attack. Don't forget this line. Very common. People go and strain for stool and they are found unconscious in the bathroom. They have done a valsalva. They applied a lot of strain over there. That can induce syncope. Premonitory symptom, another thing, is usually not seen in seizure. Why nausea, tiredness, diaphoresis, all these things premonitory before that is commonly seen in syncope. We have discussed this in the previous class also. Posture at the onset is variable in seizure. While it's always erect, standing or sitting can be anything in syncope. Transition to unconsciousness, often immediate in seizure, gradual over seconds in syncope. Duration of loss of consciousness, very important. It's in second for syncope, it's mere minutes in seizure. Duration of tonic-clonic movements, it's very short, 30 to 60 seconds for a patient of seizure. More than that, less than that, 15 seconds for syncope. Now this is important. Facial appearance during the event. Facial appearance during the event. If you remember syncopal attack, patient had a hypoperfusion. Whenever you have a hypoperfusion in the extremities, don't think the cyanosis occurs. Initially paleness occurs. So the patient of syncopal attack during the event will always be found pale. If you remember seizure we have discussed, they're going to have cyanosis. Disorientation after the event. Many minutes to hours happens for seizure, less than 5 minutes for syncope. Aching of muscles, that's very non-specific. Okay. Tongue bite, yes, we have discussed this also. Tongue bite occurs in both. We have discussed this. Tongue bite occurs in a lateral margin in seizure, on the tip in syncope. We have discussed it previously also. Urinary incontinence occurs in both. Now look at this. Fecal incontinence. Somewhere in Harrison, the first volume, they have written this. Fecal incontinence is seen in patients of seizure, rare in cases of syncope. Headache. More common in seizure, less common in syncopal attack. I agree. Premonitory symptom you can connect with GTCs. I agree with your thought. Okay. But I'm just looking at the premonitory symptom. Like Is it always there in syncope? Yes, it's always there in a syncopal attack. While it may not be in a kind of a myoclonic phenomena or maybe a focal seizure. Cyanosis occurred in seizure. We discussed the ictal phase. There is a tightening of everything, especially the laryngeal inlet. Don't worry, I'll share it on the Facebook club also. Okay. So that's a theoretical topic, but you have to know this. So what is there common between seizure and syncope, which is not helpful to differentiate the two? Tongue bite. Headache happened in seizure. Yes, we have written this. Headache happened in seizure, unlikely in syncope. Fecal incontinence occurred in seizure, not in syncope. Seizure and syncope are different from the facial appearance. Seizure, we have discussed in the very first class, cyanosis occurred, syncope attack, pallor happened. While tongue bite happens in both of them. Now the next question is easy. Okay. The image is a section of basal ganglia. Chorea occurs due to lesion in which of the following marked structure? Please remember, chorea occurs due to lesion in caudate nucleus. Right? If you look at this structure, which is the medial most, is nothing but your thalamus. When you look at this wala, B is the globus pallidus. Oh, sorry. The putamen or the putamen. C happen to be the globus pallidus externa interna, and A is the caudate nucleus. Chorea occurs due to lesion in caudate nucleus. Where is it located? Answer is A. Simple. So image based questions are also easy, but you need to have an inclination to solve them and an eye on them, how to solve them. Now question this. Patient complains of a violent form of a choreiform movement. Read the lines. Violent form of choreiform movement involving the proximal limb unilaterally. Now can you tell me what movement disorder am I looking at? Is it chorea in the proximal limb on one side? What is this movement? Yes, good. People are telling me right answer. Hemibellismus. Large amplitude fringing movement. Identify the structure below which the lesion is most likely to cause the problem. If you remember, hemibellismus happened due to lesion in subthalamic nucleus. That means it is below the thalamus. Now where was thalamus? D. So my answer is D. It is just below the thalamus. Okay. So easy guess, easy answer. Why are they known as choreiform movements? Now, because hemibellismus also looks like a dance. If someone invites me to a dance floor, okay, I'll always dance with a hemibellismus, right? Now look at question number 14. Very slow, irregularly twisting movement, one movement purposely blending with the other one. Very slow twisting movement, one movement purposely blending with the other one is known as what? Yes, athetosis. It's a typical crawling movement description that you know. Right? Now people are asking me a question about this, sir. What is tics? Rapid, repetitive, coordinated stereotype movement. Look at the name. Rapid, repetitive, coordinated stereotype movement. Like I've got tics. I keep on moving the lips like this. I've got tics. I keep on moving the hand like this. So these are rapid, repetitive, coordinated, stereotype movement. That means the same movement will happen over and over again. Tics. That's the typical definition of the word tics. What are tics? Like, you know, we have some people as tics in our society also. Total ignorance of culture that we know. They keep on doing bad things over and over again. Yes. So this is a rapid, repetitive, coordinated stereotype. Like people with tics are like this. They may be blinking the eye continuously. Okay. So this is known as a tics. Now look at this. Which of the following is true but essential tremor except? Yeah, hitchki. Yeah, can be a hiccups also tics maybe. Which of the following is true but essential tremors except? Is the most common movement disorder? Yes. Symptoms are bilateral symmetrical? Yes. They have got relatively large handwriting? Yes. Head muscles and voice are not affected? No. I've told you yesterday, head muscles, and the voice is affected in patients with essential tremor. Tics don't have any kind of a lesion as such. They don't have any definite site for lesion. They're more of a psychiatric problem that the patient acquires. Parkinson may be caused by all except very silly question. Reserpine is a dopamine depleter. Methyl dopa is also a dopamine depleter. Metoclopramide is a dopaminergic antagonist. Phenytoin has nothing to do with Parkinsonism. Simple. Okay. Which of the following is false about Parkinsonism? Now, LRRK2 gene mutation is the most common cause of the familial Parkinsonism. True. Mean age of onset is 60 years. That's also true. Lewy body are seen in autonomic system and olfactory. Now you might start fighting with me. Sir, autonomic, how dare? Autonomic, no sir. Autonomic, no sir, that is MSA. But we find Lewy bodies sit over there also in them, later stages. An olfactory system, I was stressing on this, could result in anosmia as a typical complaint in them. But is it the most common neurodegenerative disorder? We've discussed this yesterday. The most common always is Alzheimer. Okay. Not D, please. Don't mark D. Mark it as A. Not a feature of Parkinson include all except non-motor feature. Sorry. Sleep disturbance. Yes, they have REM sleep disturbance. We have seen them. Cognitive impairment in a sense of dementia. Loss of smell. Yes, anosmia. Cognitive impairment goes in sense of dementia. Loss of taste. No. They have loss of smell, anosmia, not loss of taste. Now someone was asking me, sir, investigations before treatment, I am to write a long note. This is the easiest question ever. Which of the following is the most useful diagnosis for the diagnosis of Parkinsonism? There is no investigation done for it. It's always one thing, clear cut. What? Clinical examination. Okay, don't forget this. Simplest question ever. I always remember my college professor used to always tell me Parkinson is not diagnosed by an MRI or CT or maybe EEG or some other test. It is always diagnosed clinically, like a patient walks into your OPD with a fascinating gait, with a resting tremor. It's enough for diagnosis for this. Okay. You might ask me this, a therapeutic response to drugs. Okay. Some people do have a query on this. So levodopa responsive or unresponsive. But still I believe that somewhere clinical examination is always having an upper hand to diagnose it. Okay. Now the image based question comes in. Someone was asking me, what is a gait in cerebral palsy? I'll come to that later. You can tell me this image D2. What is this? This is a fascinating gait of Parkinson patient. Yes. This wala is what? A high steppage gait of foot drop patient. And this is a child who is a case of myopathy because he is trying to waddle on both the sides. Okay. Now what is this? He is trying to cross his legs in front of each other like a scissor. Right. I'll just take you back to the yesterday's class. Got some video there. When I'm taking the right leg ahead, it crosses the left. When I take the left ahead, it crosses the right. Because there is a lot of spasm seen in the adductor group of muscle in patients of spastic CP. They try to cross the legs like this, like a scissor. So this is very typical. It's not the circumduction, my dear friend. Don't mistake it as circumduction. Circumduction, we take the support of one side and we rotate it like a compass round. This is a scissoring gait. Okay. Fine. So that's a typical gait, scissoring gait that you find. Scissoring gait, as I told you, is seen in patients of spastic cerebral palsy. Cerebral palsy with spasticity in both the lower limb. Like for example, you're walking to the toilet with a full bladder. You'll always walk with this scissoring gait. Just imagine that. So where do you match everything? Yeah, which is the best answer? I think so. The first one is Part-6 CP. The one goes with the 3. Okay, the second one goes with Parkinson, that goes with 1. The third wala goes with a high steppage, that is foot drop, 4. The fourth wala is myopathy proximal 2. Okay, 3142. 3142. That's the order correct, right? Clear answers. Which are the following points to a diagnosis of idiopathic Parkinsonism? That means it means Parkinson disease without any reason, known as idiopathic Parkinsonism. Does it first present with a history of fall? Remember this, if a patient of rigidity and extended posture comes with a history of fall initially, he is a case of PSP. First presenting with a history of dementia is Lewy body dementia. Prominent postural hypertension is multiple system atrophy. Where are we left with? Unilateral onset of tremor. If you remember, tremors happen unilaterally and they are the earliest symptom in patients of Parkinson disease, idiopathic Parkinsonism. Paralysis agitans, or the great word Kampavata. Okay. No on effect in Parkinson refers to. That's not a medicine question, it's an English question. The word is no on. I gave a patient of Parkinson a drug and he doesn't respond, he doesn't go into on. No response at all to a given dose is known as a no on effect. Loss of benefit following the individual dose, yes, is known as a wearing off effect. Wearing off effect. The on off phenomena is just trying to tell you wearing off effect. Delay in turning on the response. Yes, delay in turning on the response is known as a delayed on effect. क्या हुआ? अभी रुक 10 मिनट. Okay. Right. Because in my house when I'm taking class there is a Janta curfew going on. People are waiting for 9:30 for the release of Janta curfew. Okay. So that's the correct answer for the previous question. Simple. Which of the following symptom changes in on-off phenomena during levodopa therapy except? That's a very simple thing. On-off phenomena. Okay. That means the patient on levodopa therapy goes on and goes off. There is hypertonia. The word hypertonia means that there is hypertonia followed by decrease in tone. The tone word hypertonia doesn't mean flaccidity here. Don't take it like this. When the tone increases and the tone becomes normal, comparatively the tone is less, hypertonia. Unsteadiness of gait, yes. Akinesia, yes. Tremors, no. Tremors happen due to increase of acetylcholine. And if you remember, this on-off effect doesn't have any fluctuation on the acetylcholine level. Okay. Wheelchair sign of Quinn is typically a red flag sign. Now people are asking me this for the last 2 days. It's a very old sign. When this question came for the first time, every student very proudly marked the answer as DMD, Duchenne muscular dystrophy. I asked them how. They all gave me a logic. Yeah, sir, now I've read this in Peds and Medicine that in patients with DMD, by the age of 12 years, they come on a wheelchair. So that is a bad sign. It is a red flag sign for them. They're going to die by the age of some further 18 or 25. Oh my God. Don't have this idea, please. In a patient of Parkinson, this has nothing to do with DMD first of all. In a patient of Parkinson, you start with the levodopa therapy. And you find good thing in the patient that they turn on. But we found that the patient of Parkinson on levodopa therapy that we started came in the next visit, that is on a wheelchair. Maybe he is trying to have this no on effect. That means he did not benefit. If there is a no on effect, what does it mean? It means in the patient is more likely unresponsive to levodopa. Okay? That means if they are unresponsive to levodopa, what am I seeing? I am seeing this as a case of Parkinsonism plus or atypical, which they don't respond so well. So look at this. In idiopathic Parkinsonism patient, Parkinson disease, When I start them on levodopa and they are totally dependent on wheelchair now, that means it's not working, it's a no-on effect. It's a bad sign. It's a typical red flag sign for them. The word red flag means a danger sign. That means it's not a case of Parkinson at all. It's a case of Parkinsonism plus atypical. So what do I do? Idiopathic Parkinsonism. Correct answer. Quinn was actually some neurologist somewhere in France who found this first. I'm not good in that history part, but still the word Quinn came from him. Which of the following is a pain sensitive structure in the skull? We have already answered this in the previous class. Dural sinuses. They are pain sensitive. Arachnoid matter, dura matter. Please remember they are pain insensitive. Ventricular ependyma is also pain insensitive, but dural sinuses any time are pain sensitive. Now you might ask me, sir, in patients of subarachnoid hemorrhage, we had a lot of headache, thunderclap. Then if the arachnoid matter was pain insensitive, why so much of pain occurred? Look at this, in the meninges there are vessels running. Over that point where the vessels are running, that's typical small point is found to be pain sensitive. Most of the meningeal layer are pain insensitive. Okay, dural sinuses anytime are pain sensitive. Yeah, this question has been following with me on the Facebook again for a lot of time. 2-3 questions on temporal arteritis. Female to male ratio is 4:1. That's fine. It's more common. Emeresis fugax is an ominous sign. Ominous means a bad sign. Black screen is a bad sign. Your app will hang. Yes, because if they are having transient loss of vision, that means they are having a problem in the ophthalmic area. They will go into blindness and they will be never reversible. Steroid therapy is guided by the ESR. Yes. Steroid therapy is guided by the ESR. Yes. Even a smaller biopsy specimen can diagnose the disorder. Very clear statement. We require a longer biopsy specimen. Can you tell me the length? What length is there? The range of it? How much? 5 centimeter to 3 centimeter. Okay. Which of the following is true about temporal arteritis? Right. I've seen this question somewhere in our DQB also, and unfortunately the answer went wrong for it. True statement. More common in middle-aged males? No, it's more common in elderly females. Hemiparesis is a common associated feature. No. It's not very common. Raised ASR is essential for the disease. Now I want to stress on this also. Somewhere if you find the disease is chronic, for example, the disease is very old. In a sense, the area which was there inflamed in the temporal artery has got totally fibrosed. What will happen in the patient? Most of the time their ESR would be normal. It can happen in the later stages. That means in the later stages of the disease, you might see that the ESR may turn normal. So raised ESR is essential for the disease is not a true statement. Be careful now. Blindness is a preventable complication. I always say it's preventable. Yes, I can prevent it by giving steroid therapy at the right time. But if at all it is occurring, it is always irreversible. It is always irreversible. Okay. So this is a true statement. Not D but C is a true statement. This 29 question number we have already solved. In words earlier in the class, 75-year-old female complains of unilateral throbbing headache with pain in the jaw on chewing. She has a low-grade fever with stiffness, pain in back on the shoulder, back, everything. So look at this. She has got pain in jaw on chewing the food, jaw claudication, unilateral throbbing headache with pain and stiffness on the neck and back. If you remember that, polymyalgia rheumatica. What is true about her condition? Yes. Start with steroid immediately without waiting for the biopsy report. We've discussed this in the class also earlier. It's a very clear answer. Good, you all know it. This is something memory based. I really cannot help you. But whenever you have an option like all of the above, feel comfortable. But whenever you have an option like none of the above, feel uncomfortable. Okay. So look at this. Which of the following is a cause of pseudotumor cerebri? Hypervitaminosis A, hypoparathyroidism. Even if you don't know the B answer option, you can comfortably go with D, all of the above. Okay. I've tried to discuss this thing also in the previous class. The headache of raised intracranial pressure is typically associated with worsening with coughing, sneezing or bending, fortification spectra, stabbing or shooting pain, better, better on waking first thing in the morning and worse on standing. Now everyone read worse on standing, okay, this must be raised ICT. No, no, no. Raised ICT, yes, 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 yes. It is more on awakening, it's not better on waking the first thing. Okay, it's not better on waking up, it's more on awakening, and it is aggravated on coughing, sneezing, and bending. See, why happens when I cough, sneeze, or I bend? There is a constant movement of the CSF in any form of the area where the CSF is stored, and that will cause some kind of a traction of force, and the pain will rise. So don't mark D actually as a correct answer. Mark it as A. Where does fortification spectra come in? Migraine. Yes, you remember? Stabbing and shooting pain is a non-specific, I can think. So please don't forget, don't mark D in a hurry. It's not better on waking. It's worse on awakening. It might get worse on standing also sometimes, but it is more worse on sneezing, coughing and bending over. Okay? So A is better than D. But this part is not totally correct. Which of the following is true but not true about migraine? What's false about migraine? Pulsatile headache is a characteristic type of headache. Yes. More common in females? Yes. Decrease in severity during pregnancy? Yes. Lifelong prophylaxis is required? Nah, Baba. The prophylaxis that we require is for 5 to 6 months time. Not lifelong. Activation of the brain vessels in a migraine attack is mediated by what? CGRP. CGRP. Okay, if you remember this. Which of the following is the least prominent in acephalgic migraine? Another kind of a Yorker kind of a question. Headache. Acephalgic. People are running after this acephalgic. Sir, how will you diagnose? I've seen this on Facebook also. See, in acephalgic migraine, the word is acephalgic. There is no headache as a symptom. Okay, they might have nausea, vomiting, even vertigo could happen. That means they might just have few facts like aura. Now look at this. Aura can happen. They might have nausea also as a complaint of migraine. Yes. But what happens in them, one thing is typically and always missing. What? Headache. Headache is always missing. So people do ask me, sir, how will you find it? Can it be a psychiatric problem? Yes, I can mistake this as a psychiatric problem. I can mistake this as a psychiatric problem. But the point here is the treatment is always same like a patient of migraine. So they happen to sit in a classification part of it. Now don't mark vomiting, don't mark nausea, don't mark vertigo. One thing which is totally missing in a patient of acephalgic migraine anytime is headache. Headache is always missing in them. They are just patients of migraine with aura. One thing can have even nausea, vomiting complaints and even vertigo. Okay. But something which is never ever seen is always a headache in this. Treatment again is the same like a patient of migraine. They end up having the same kind of a treatment. Okay, so be careful on these kinds of one-liners. In a hurry, you might just mark anything else. Thinking vertigo can happen anywhere else, nausea, vomiting can also happen. But one thing which is least prominent in the sense never happens is headache. Which of the following is true regarding tension type headache? It is associated with nausea and vomiting? No. Amitriptyline is the only approved drug for episodic tension headache? No. For that, if you remember, we have written analgesics were approved. Chronic occurs when it occurs on daily or near daily basis? No. More than 15 days in a month? That's a correct definition. Tension is an etiology? No. Okay. Which of the following is correct about myasthenia gravis except? More common in females? Yes. Late onset in males? Yes. Early onset in females? Yes. The remission is complete and permanent? No. Don't think they will get normal in their life. I was very well stressing on this point. They are becoming, after thymectomy, disease free or symptom free. If you remove the real source of the antibodies, then only. But most of the time the antibodies are of the IgG type. Correct? So what do you have now? You have to give the treatment lifelong to them. Right? Which of the following antibodies in a patient of myasthenia gravis can be seen? Is it anti-CCP-ANA, anti-TPA? No, it's anti-LRP4. If you remember the other two, MuSK antibody, acetylcholine receptor antibodies. Which of the following drug may exacerbate weakness in myasthenia gravis patient? Okay. Tricky question. I asked a student what's the correct answer. He gave me the answer amlodipine. I asked him why amlodipine. He gave me explanation also, sir. Amlodipine and even verapamil are calcium channel blocker. They will block the calcium channel which was present on the nerve. So if the calcium doesn't come in, the acetylcholine will not go out. Oh my god. What an idea you have got. The answer is LOL. Metoprolol. This you do discuss in your pharmac classes. There are certain drugs which are exacerbating weakness in myasthenia. There is no clear reason why. No clear reason why, but these drugs are like this. Antibiotics. The antibiotics that we have with us are the quinones and the aminoglycoside. Aminoglycoside and the quinones that we have with us are the antibiotics which are going to exacerbate all these. Yeah, your all NMDA kind of receptor blocker maybe. Can be a D-tubercularine. Yes, that can also do. And of course, don't forget the beta blockers, which are LOLs. They can exacerbate the weakness in myasthenic patient. Pathogenic antibody, acetylcholine receptor in myasthenic patient. Which type is it? If you remember, we have discussed this. It's of the type IgG. Okay. You mark ceftriaxone as thinking antibiotic. Which of the following is true about MuSK? False about MuSK. False. Transmembrane component of the postsynaptic neuromuscular junction. Yes, it's a component of a postsynaptic membrane. Okay, across the membrane you can see this. It is activated by the binding of the agrin with LRP4. This way also we have done. Myasthenia gravis with MuSK antibodies are rarely associated with hemoma. I've cleared this concept that there is not the right factory for this. MuSK antibody positive patients respond well to pyridostigmine. Now that's the drama that you should all know. They do not respond to pyridostigmine well. Because the problem here is a clustering of the receptors. The receptors are not together here. The problem is this. The receptor is a normal receptor like this. In patients of myasthenia gravis, the receptor goes like this. They are not clustered. Even if I increase the acetylcholine level in the synaptic cleft by giving a pyridostigmine, it is not going to benefit the patient. So remember two things. MuSK antibody positive patients. One, they are poor response to thymectomy. One thing. And poor response to even pyridostigmine. Some fugax is happening, don't worry. It will be fine. Okay. So this is something wrong. In a patient with myasthenia gravis, on raising the ptotic eyelid, the opposite eyelid falls. What is this? I am raising the ptotic eyelid of the patient and the opposite eyelid comes down like a curtain. Is known as what? The curtain sign. Okay. Improvement of weakness in myasthenia gravis is seen over 1 to 3 months by use of which of the following immunosuppressive agent? Yes, except mycophenolate, mofetil and azathioprine. Say hi. Come. Say hi. The kids have come. Bhaiya Didi is there. Abhi dikhate hain. Wait for 5 minutes. हाँ, don't make noise please. Janata curfew is ended on time in my house. Sorry for inconvenience. Improvement of weakness in myasthenia gravis is seen in 1 to 3 months by use of which of the following immunosuppressive agent? Except MMF. That comes quite late in the disease. Okay. A person shows improvement in ocular weakness on receiving hydrophonium in the ocular, facial and the skeletal muscle. Which of the following statement is true about the treatment of the patient? That means it's a case of generalized myasthenia which is improving on giving hydrophonium. Correct? What is the true statement about the patient? Please tell me. Patients with ocular myasthenia have a bad prognosis. That's not a correct statement. We found that ocular myasthenia don't progress. Okay? And they remain ocular lifelong most of the time. Immunosuppressants like azathioprine are used only in myasthenic crisis. No, crisis have IVIG plasmapheresis. Must positive patient go into complete remission after thymectomy? I've explained this earlier also. They don't respond well to this. Thymectomy is indicated in the absence of thymoma. Yes, that was a correct statement. Reason that we do thymectomy in every patient of myasthenia gravis except, in spite of medical control. Most of the times it's hyperplastic lesion. Even in the absence of thymoma, we do it. So thymoma, I again repeat, is the most useful indication, not the only indication to do thymectomy. Okay. Which of the following is true about the patient having this following sign positive? Can you tell me the sign? Is it the Kerning sign or the Brudzinski sign? Which sign is it? I've shown you in the class also. It's the Kerning sign. Yes. Okay. Now, which of the following is true about a patient with a Kerning sign positive? In this previous question, I've written this. There is improvement in ocular, facial and skeletal. I only had the picture, the image of the patient in the side. So I could not show him the whole body. Okay. So it's generalized. Now, this sign is positive in patients of infective meningitis only. That's not a correct statement. If you remember, these kinds of signs can happen in patients with irritation of meningeal, like subarachnoid hemorrhage. They also have got neck rigidity. They can also have signs like this. Seizure never occur or never seen in this condition. I've explained this in the class also. Seizure do happen. Presence in all patients of meningitis irrespective of this age. If you remember, I've written this in the class notes also, that these signs of neck rigidity or meningeal irritation are commonly absent in elderly, young, very young or maybe in neonates, and of course patients who are immunocompromised. If you remember, antibiotics should be administered within 60 minutes of arrival. That's a correct statement. That's a very correct statement with us. This a patient with fever, headache, neck rigidity, altered sensorium, stabilization of the patient done, and the LP was done, which was slightly blood tinged. Cell count, first year biochemistry, okay. Second year microbiology, okay. Third year counting the number of years, and fourth year Brahmasmi, preserve. Okay. So the cell count is always looked in the third one. You know the answer, correct. Good. 50-year-old male comes with fever, headache, decreased level of consciousness. On examination, the neck rigidity is present. CT scan is normal. What is the next step? Someone corrected this question in the Facebook. Thank you very much, whosoever it was. Now remember this. DEXA is the first thing and the priority to be given. You don't go with antibiotics initially. So I'm asking you, what is the next step? First DEXA followed by the antibiotic. That's a clear statement. Okay. Now, a few questions here and there. Which of the following is not seen in TBM? There is evidence of a pulmonary lesion or mammillary pattern in chest X-ray. That's a true statement. That's a correct statement. If you connect with this in the ward, most of the time they have an old focus of a pulmonary lesion. Most of the time. Culture of CSF is diagnosed and remains gold standard. I've clarified this. Yes. It is often seen in young children, but also doubles in adults. Yes. It occurs in young children very often. CSF reveals a low leukocyte content. No, it's a totally wrong statement. It's always a pleocytosis, which is a lymphocytic seen in them. Okay. Sorry, my kids are making a lot of noise. Sorry. Predictors of increased mortality in bacterial meningitis include onset of seizure within 24 years of admission. Yes. Glucose, low protein. Have you written this in the last class also? Which of the following is true about herpes simplex encephalitis? That's an easy question. Never associated with a low CSF glucose. CSF is often normal. Imaging may show secondary hemorrhage in the temporal lobe. EEG shows slowing of one of the both frontal lobes. What is true statement? The true statement is imaging showing secondary hemorrhage in the temporal lobes. So we find the hemorrhagic lesion typically there. Now slowing of the changes is in the frontal, I agree, but it is more typically in the temporal area. Correct. CSF is normal. No, that's not a correct statement. Low CSF glucose, no, that's not a correct statement. You know, it is never associated with a low CSF glucose. Is it true or not? Okay, but the better answer anytime is a secondary hemorrhage in the temporal lobe, because we find the hemorrhagic lesion typically there. If we can connect this on the MRI looks at what? Hyper intensities. Okay. Okay. True about PMLE. Only oligodendrocytes are affected? No. Okay. Seizure is never a clinical feature? No. Heart regimen may contraindicated in them? No. CSF is typically normal? Yes. Okay. Right. So there was a bit of fascinating gate that we saw, but all well that ends well at the end. Okay. And hope you do well in life. All the best. Stay connected with us on the Facebook club. Also, we'll be revising all these topics, and we'll be doing a lot of discussions on the questions that we have discussed. There can be some queries at your end, and if when you decide not to revise, please remember this. बड़ा पछताओगे जब एग्जाम में रिवीजन नहीं करके जाओगे बड़ा पछताओगे. Class is not yet over. There's a big surprise for you guys. Okay, get up from your seat, we're going to dance. Okay, get up from your seat, we're going to dance, and we're going to play a very old music. It might seem crazy